أنا شاكر جدا لأستاذ الدكتور مجاهد على الكلمات الرقيقة الجميلة اللي أنا ما استحقش حاجة منها يعني على أرض الواقع. يمكن زي ما الأستاذ مجاهد قال time range is coming as an important parameter for assessment of glucose control, and I think it will shape the future of diabetes control in the coming few years. This is my disclosure, and this is my agenda. First of all, I want to give an idea about the present situation of glucose monitoring and the glycemic control monitoring, which can be assessed at the present time with hemoglobin A1C with continuous glucose monitoring using either target range or the mean glucose or the glucose management indicator, which is an estimation of hemoglobin A1C from the continuous glucose monitoring, and blood glucose monitoring, which is using can be assessed by using the glucometer, as we know. Hemoglobin A1C is the most important and the gold standard in the study assessment of effect of glucose control on the diabetes outcome. And individual glucose monitoring also using the glucometers is very important for taking decisions regarding the daily change of the insulin doses and management of diabetes regimen. Continuous glucose monitoring is coming, and it is rising in its importance in the management of diabetes, as we said. These are the drawbacks of the old methods. That's why we need new methods for assessment of glucose monitoring. Hemoglobin A1C, which is the gold standard, as I said, does not measure the intraday or intraday variability. That's why we cannot have real glucose measurements to take decisions regarding the change of rapid change of anti-diabetic regimen. Also, it is affected by some abnormalities like anemia, hemoglobinopathies, and there is racial variation also in the which can affect the glycation and the level of hemoglobin A1C. This is a famous curve. I think you saw it before. We have many patients who have the same hemoglobin A1C, which is 7%, but some patients have hypoglycemia, others have hyperglycemia, and this is the best group which has a curve which is called flat range. Which patient has good control of diabetes despite the fact that all of them have 7%? The only last one, while the others have no good glucose control. The self-monitoring of blood glucose, it is a snapshot of measuring of diabetes at this moment. And it does not show the variation of blood glucose from measurement to the other, plus the pin break, which is painful and the patient does not like it. This is the time range which is assessed mainly with the continuous glucose monitoring, while we can assess the time range using the self-monitoring of blood glucose with a certain formula, but it is not accurate because the frequency of measurements is low. And the sensors available for the continuous glucose monitoring, as you can see, some of them are professional, which are used by the healthcare centers, and the results are shown only by the healthcare provider. And there are some self-monitoring devices which are used by the patient. And across the time from the innovation of continuous glucose monitoring, as you can see, from 1990 till now, what we call the absolute relative difference of the sensor sensitivity and the sensor accuracy is improving. As the figure is low, the accuracy is much better. That's why we have now accurate sensors of continuous glucose monitoring. These are the personal available continuous glucose monitoring devices. The Abbott has 3 continuous glucose monitoring devices. The Libre 2 and Libre 3 is available now, and Dexcom has the G6 and Medtronic has the Guardian. And this is the long-acting from Sensonic, it is the Eversense, and the sensor can be used up to 90 days. But the problem with the Eversense is that the sensor must be applied by healthcare professional and not by the patient. These are the parameters which you can get from the continuous glucose monitoring devices. The device should give you the time in which it was active. And as long as the activity is high, the other data will be reliable. And it gives you the time range, blue range, above range, and gives you the estimated hemoglobin A1C, which is the glucose management indicator, gives you some data about the glucose variability using the standard deviation and the coefficient of variation. And I will show you an example of the data which can be driven from the continuous glucose monitoring. This is the time in which the sensor was used for 14 days and it was active all the duration of use, which is 100%, and the average glucose was 175. And this is the estimated hemoglobin A1C, which was 7.5, and the coefficient of variation was 45, which indicates a significant variability of blood glucose. The data which are extracted from the continuous glucose monitoring over 14 days can be presented in a glucogram, which is the ambulatory glucose profile, which shows the data as if they are happening in one day from 12 midnight to 12 midnight, which can show you the variability of blood glucose by a glance. And this data can be presented day by day to see which days the glucose was variable, the risk of hypoglycemia was higher in certain days, the risk of hyperglycemia was higher in another day. And this can be correlated with the lifestyle of the patient and any derangement in the course of diabetes management. These are the indications of continuous glucose monitoring from the UEDA 2022. All patients with type 1 diabetes, either youth or adults, using multiple daily injections of insulin or subcutaneous insulin infusion should be on continuous glucose monitoring, while patients on type 2 diabetes who are using basal insulin can be offered continuous glucose monitoring. Type 2 diabetes on multiple daily injections of insulin or subcutaneous insulin injection infusion pump should be used continuous glucose monitoring, and the device should be active most of the time to get proper data. Sometimes the patient has some sort of skin reactions and they are not tolerating the device, and sometimes there is an economic issue. That's why intermittent real-time continuous glucose monitoring or intermittent scanned or professional continuous glucose monitoring can be used to improve the diabetes control. This is the time range difference in the different populations. This is what is known. According to the data from ASD and American Diabetes Association consensus on the treatment of diabetes, the hemoglobin A1C target is variable according to different parameters. The same is there for time range. There is a difference in the target and the time range for adolescents with type 1 or type 2 diabetes. And let's look to this figure in the box at the lower part of each compartment of the screen, and the upper part and the middle one here. In type 1 diabetes and type 2 diabetes in adolescents, the target is from 70 to 180, and the patient must be in target 80% of time in type 1 diabetes, 70% or more in type 2 diabetes. And in adults, the target or the time range is from 70 to 160 or 80. And if the patient is going to be in the time range from 70 to 160, it should be in this time range for 70% or above. If it is relaxed from 70 to 180, you should be in this time range for 80% of the time. In pregnancy, type 1 or type 2 diabetes or gestational, the time range from 63 to 180 milligram per deciliter. This is the range, and the time range should be above 80%. and in elderly, the target is relaxed from 90 to 200 milligram per deciliter, and the patient should be in this target above for about 80% of the time, and should not be less than 70 milligram per deciliter more than 1% of the time. Patients who are at high risk of hypoglycemia, either they are suffering from some sort of renal disease or liver disease, the target is from 80 to 180, and he should be in this target for about 70% or above. Patients who have macrovascular complications, the target is relaxed from 80 to 180 milligram per deciliter, and people with concomitant infection and they are hospitalized, the target is from 140 to 180 and should be in this target for more than 80% of the time. And if they are not hospitalized, the target is from 80 to 180 and should be in this target for more than 75%. But are these levels and durations to be in the target of blood glucose of value in the long run and long-term management of or reduction of diabetes complications? Yes, they are correlated with hemoglobin A1C. The time in range is related to the reduction of hemoglobin A1C, as you can see in this figure. Theoretically, it will be reflected in improvement of outcome of diabetes. This is what is known from United Kingdom prospective diabetes study. Reduction of hemoglobin A1C by 1% resulted in significant reduction of microvascular complications, amputation, and numerical improvement in fatal and non-fatal stroke and myocardial infarction. The same was shown by the TCCT trial, in which hemoglobin A1C reduction improves the microvascular outcome. Correlational studies from retrospective data for time in range, and the most important, used the data from the DCCT trial using time in range extracted from 7-point measurement of self-monitoring of blood glucose, showed that reduction of time in range by 10% resulted in 60% increase of risk of fructinopathy, 40% increase of risk of microalbuminuria, and 25% increase in risk of peripheral diabetic neuropathy. Theoretically, again, improvement of time in range will lead to reduction of microvascular complications. Some data also showed that improvement of time in range will improve the all-cause mortality and the cardiovascular mortality and increase the cumulative survival. As we can see, the higher the time in range, the lower the all-cause and the cardiovascular mortality. This encourages some authors and some research authorities to find other time in range. This is a study which was carried out on veteran groups in the United States of America. They used what is called hemoglobin A1C time in range. They classified the patient with high cardiovascular risk with hemoglobin A1C target from 8 to 9%, and patients with low cardiovascular risk, hemoglobin A1C target was 6 from 7. As long as the time in range was higher in the hemoglobin A1C categories, they found that higher hemoglobin A1C time in range showed improvement in micro and macrovascular complications. But it is not always good. Some drawbacks are there for the continuous glucose monitoring, including the safety issues, including the skin reactions, including the trauma and the loss of the sensor and the pull of the sensor, including some sort of technical issues, as we need calibration and recalibration of some sensors. Only the Dexcom sensors and the freestyle Libre sensors do not need calibration. Sensor malfunction may happen and may develop in some situations, especially in low and very high blood glucose, giving false readings, and during prolonged aerobic exercises. And the most important, especially in the Western countries, and should be everywhere, the data gained by the continuous glucose monitoring. In summary, continuous glucose monitoring and the time in range is a new era in the control and follow-up of diabetes control, which can help to take rapid decisions in the change of management regimens, especially of insulin, and it is correlated to the risk of micro and macrovascular complications of diabetes. And we can improve this time in range by certain steps, including exercises, including low carb diet, including intermittent fasting, and using some new insulins, which are long-acting basal insulins of the new generations, which can improve the time in range. And thank you.